So I'd like to welcome Professor Giovanni Paganelli, who comes to us from Milan, Italy. He's the Director of Nuclear Medicine at the European Institute of Oncology in Milan. He has a special interest in the Avidin biotin system in the diagnosis and therapy of solid tumors, particularly for breast. And the other area for which he's now well known is ROLL, ROLL, radionuclide occult lesion localization, which he has innovated, and some of us here have actually gone to his site to learn. So now he's going to tell us the European experience on PRRT. Italian experience, which is
well, we are European now. No,
sorry.
almost. Thank you very much, Mr. Chairman, for your kind words and presentation. Yes, indeed. I mean, my first lab was the pre-targeting with Avidin biotin, and I will talk tomorrow. And also, since I work at the European Institute of Oncology with Professor Veronesi, I mean, it's mainly breast cancer, but it's a cancer center, and we also see many neuroendocrine patients, and we started 15 years ago doing peptide receptor radiotherapy in collaboration with Meke, and is actually a small group in Europe, the peptide community. But now I see that it's growing, and this is very good to know as well. With Richard, we communicate. I remember, and unfortunately, it's more than. I mean, it was in the other century. So what we tried to do in Italy, in my department, was to organize mainly phase 1 trial, because what I would say that regarding this approach, which is a academic and spontaneous approach, because no company were behind our study, since Novartis decided not to invest very much in the radiolabeled peptide. They prefer to invest more in the non-radiolabeled peptide. But if you remember the story of the Trojan horse, the war between Athens and Troy, you remember that they put soldier into the horse, and then the horse went into the Troy city, and then they destroyed the city. The radiolabeled peptide, I mean the Trojan horse with the soldier inside. This is the concept. And in Italy, we started in 96-97 in Milan, the European Institute of Oncology, and then after a few years, since I was born here in this area of Italy and I studied in Bologna University, I mean, we start also in this other hospital, and then in another hospital in Macerata, and then in Naples, and then in Messina. And this other center were ready to start. Actually, some of them, like this Reggio Emilia, already started. Here in San Giovanni Rotondo, they do something, and here they're going to start. So, so far, I mean, there are many centers already, I mean, ready to start, or that started with peptide radionuclide and soon in Europe, a company called AAA will start a randomized phase 3 trial for registration of lutetium dotatate. As I said, what we did in my institute was mainly phase 1 trial, because the Rotterdam group and the other group, I mean, they did an excellent job, but most of the paper were retrospective. I mean, what we did was, first of all, a phase 1 trial, prospective study, to understand what is the maximum activity per cycle and what is the total maximum activity that can be tolerated by the patient without amino acid protection. Because if we inject immediately 2 drugs in the same phase 1 trial, you don't understand very much, the toxicity. And this was published in the late 90s. And then we did the trial with amino acid plus yttrium-90. And then we did the prospective phase 1, phase 2 trial with the lutetium. So this is the contribute of the Italian group. I have the fortune to have Lisa Baudet and Marta Cremonesi in my group, and Marta Cremonesi is an excellent physicist, and we did a lot of dosimetry. And so we focus our attention on kidney protection, renal toxicity, and recently we did phase 2 prospective trial in pancreatic and in intestinal neuroendocrine tumor. And recently also we focus our attention on the role of FDG PET in neuroendocrine tumor, as Richard mentioned in his excellent presentation. So, as I said, the Trojan horse, I mean, the rationale is quite strong. First of all, we can see for each patient, this is really tailored therapy. We see in each patient if we have receptor uptake or not in the disease documented at CT. And similar to the non-labeled peptide, which has some action, I mean, to interfere with the growth. Of course, these are tyrosine kinase, network. But if we label our peptide and then our peptide is internalized like the Trojan horse, I mean, then of course the radioisotopes can deliver the energy, or the ionizing energy, to destroy the cells. So the rationale is very strong. The possibility to localize now even very small lesion, or even lesions that are not seen at the CT with the gallium, I mean, allow us to treat more and more patients with this approach. But nevertheless, if we see the algorithm of at the ESMO a couple of years ago, the European Society of Neuroendocrine Tumors, still this targeted radiotherapy with lutetium or yttrium DOTATOP are in experimental. And this is probably because, all the study in the Rotterdam group, in the Bad Berka group, in the Basel group, in the Innsbruck group, in the Milano group were spontaneous, were academic, and not sponsored by company. But nevertheless, it's quite evident that there is a strong benefit of this treatment. The molecule we are using are this. This is the DOTATOC. Please pay attention on the fact that the affinity of this peptide is very good for receptor number 2, a bit for receptor number 3 and receptor number 5. The other peptide available is the TATE, where the treninol is being replaced by the threonine, so it's more hydrophilic. And look, just changing one amino acid, and almost is the same because threonine and treninol, we change dramatically the affinity of the peptide for the 5 receptors. We only have receptor number 2 with the DOTATATE, but at a very, very high affinity. We are in the range of 1.6 nanomole. Okay? So the message is that details make the difference in science. The protocol, the phase 1 trial we did started without amino acid protection, okay, and then immediately after we did with amino acid protection. And this is the maximum cumulative activity of yttrium DOTATOC that can be injected in a patient. Of course, not all the patients are the same, so patient with kidney problem, should receive less. Generally, we divided the injection into 4 cycles. But nobody knows, and nobody have done yet a study comparing, for example, 15 gigabecquerel in 4 or 5 cycles compared to 15 gigabecquerels in 15 cycles, every week. Nobody knows, and still we missed this approach. But this is, probably you can do in the future if you start it now. But what is clear is that we cannot inject more than this amount of activity. And for example, today, after 15 years of experience and more than 2,000 patients treated, we never inject more than 75 millicurie, 3 gigabecquerel per cycle per patient, and no more than 200 millicurie. So we are absolutely, we have a completely different approach with yttrium DOTATOC compared to the Basel protocol. We never inject more than 100 millikilo of yttrium DOTATOC, never. And if you are using yttrium dotatate, you must be much more careful because of the affinity of the peptide and also the affinity of the peptide for the kidney. And I will show you some slides later. So remember, details make the difference. And it comes the first question. What is better, the yttrium or the lutetium? Which is more appropriate? Is possible the combination? And what is the timing? As I said, you know, every 2 months, every 2 weeks. I mean, so far we can also do dosimetry and comparison of lutate and yttrium DOTATOC or dotatate. For example, here we choose to compare dotatate yttrium, dotatate lutetium. Because if we compare dotatate lutetium and yttrium DOTATOC, we are comparing pear with apple, and this is no good in science, okay? And we do it through retrospective study, of course. And okay, this is the characteristic of the yttrium and lutetium. We can jump this. And for example, very okay. Simple. Here is the lutate tumor uptake. I mean, according to the receptor density and also the size of the tumor, I mean, we can have between 0.6 and 56 gray per gigabecquerel, okay? And if we compare in the same patient the yttrium, which is the yellow, and the lutetium, you see that in the kidney, the dose is much less for the lutetium. Look, the dose of the yttrium dotatate in the kidney is very high. It's 2 gray per gigabecquerel. I mean, we really have to be careful with yttrium tate. And the dose in the liver, in the bone marrow, in the spleen, okay? So, to make a long story short, I mean, the normal organs, generally, the dose delivered with yttrium is 4 times the dose delivered with lutetium. And for the tumor, of course, depends on the receptor density, on the tumor mass. Let's say that mainly the dose with yttrium is higher for lesion than less than 2 centimeter, a double. But for lesion, you know, bigger than 2 centimeter, the dose of yttrium is 4 times more. So yttrium still has an important role, especially if you want to treat, for example, intra-artery big lesion in the liver, when it's not possible to do other approach like, you know, chemembolization or embolization itself or other things. So, as in external beam radiotherapy, we can play a bit with, you know, the energy of our isotopes. So we have to balance the risk-benefit, I mean, for each patient. This is tailored therapy. So this is personalized therapy. We cannot generalize. We have to try to stratify patient, but then we have to do, for single patient, the best treatment possible. And again, what is the best peptide? The TOC or the TATE? I told you, the TOC, I mean, recognize also receptor number 5. So if we have to treat, for example, thyroid cancer, I mean, that doesn't uptake anymore the iodine, because the thyroid cancer has more receptor 5 than 2, or they are mixed, I would use DOTATOC for thyroid cancer. I would use DOTATOC, for example, for paraganglioma. I would use DOTATOC for other cancer. But in neuroendocrine tumor of the gastroenteropancreatic system, probably the TATE is better. But again, this is also, you know, policy of registration and, you know, et cetera, et cetera. Let's say that for the TATE, because of the higher dose to the tumor and the higher dose to the kidney, let's say that probably it's better to label the TATE with lutetium. I would not label the TATE with yttrium. And for the DOTATOC, maybe it's better to label with yttrium, or we can even label with lutetium. Another important contribute, I think, that the Milan group gave was the assessment of risk factor for kidney toxicity and bone marrow toxicity. I mean, we published that there is difference in terms of toxicity for the kidney expressed like creatinine clearance loss at the same biological effective dose for the kidney if we have patients with risk factor, and risk factor are hypertension, diabetes, previous chemotherapy, platinum-based, previous treatment with other peptide label isotopes. If we have patients in the normal range of creatinine, in the normal range of bone marrow reserve, but, I mean, that receive this previous chemo, or they have diabetes, they have other, I mean, we have to be careful because the same amount of activity or the same dose, biological effective dose, can turn out in a permanent toxicity for the kidney. So it's not possible to give 200 millicurie to everybody for 4 cycles. This is meaningless, in my opinion, in personalized tailored therapy. I mean, we cannot generalize. And another small contribution, let's say, of the Milan group is the cheap, simple system to inject the peptide. The peptide is labeled in our radiopharmacy, and it goes in a vial into this Perpex vial. And then, very simple, we don't touch the radioactivity. We don't put anything in a pump. I mean, we put saline solution here, and we have another long needle, the spinal needle, you know, in the bottom of the vial. So 1 drop goes in and 1 drop goes out. This is my patent, and the idea came from the wine. When I take the wine and then I put in the bottle, believe me, and I patent this. And now AAA will use this system. And it's very convenient because you receive the dose, you don't have to touch anything, you just do the control, then put a needle, short needle in the vial and a long needle in the bottom of the vial, and then open. And if the patient has some problem, and maybe when they have a carcinoid syndrome they have some problem, you just stop the infusion and you don't touch anything. So the ALARA law, as low as reasonably achievable dose for the staff and for the patient, is respected. Sometimes, let me say that I laugh when I see people that put the lutetium here. I mean, think if there's something happens, I mean, we can, you know, and in terms of dosimetry for the personnel, I mean, the lutetium, I mean, is okay, it's mild, but still, we are using 100 and 100, and we are, for example, treating more than 15, 20 patients per week. So, okay. These are some of the results that we publish in the European Journal of Nuclear Medicine. This was the phase 1, phase 2 trial with yttrium dotatate with amino acid protection. These were 140 patients treated with an average of 7.4 gigabecquerel, so there are about 200 millicurie. You see that the figure in Bad Berka, in Milano, in Rotterdam, in more or less are the same. These are patients with neuroendocrine tumor in progression. And with this approach, we are able to produce a disease control rate. That means, you know, stable disease, partial remission, complete remission. It's difficult to apply the WHO or the RECIST criteria in this kind of therapy. The disease control rate is quite high. I mean, we have 50% of patients with stable, 20% with partial remission, 4% with complete remission. And we have more or less a 20% of patients that did not respond. And this was, you know, something that, I mean, I tried to understand why they don't respond and why the other do. I mean, the duration of response, you see, this actually we could update this. It's much longer now, but this was when we published in the 2004. This is an example of a patient with a vipoma. And this patient, after 15 years, I mean, is perfectly in complete remission. So I would say that we cured this patient that had the tumor and also liver lesion. And this is the CT control 6 months after the therapy. Unfortunately, I don't have the CT control, but believe me, I mean, the patient is in an excellent condition and free of disease. This is the phase 1, phase 2 trial with lutetium that we published last year. And again, more or less are the same, the figure of the Rotterdam group or the Bad Berka. Interesting, in terms of survival, I mean, there is no big difference between patients who achieve complete and partial remission and patients who achieve stable disease. Whereas patients that do not respond to radionuclide therapy, all these patients were in progression, I mean, had a worse prognosis. And we will come back to this point. Why is this? Of course, I mean, the tumor shrinkage has an influence on the overall survival. But there are many examples in biological therapy where, I mean, this is not the case. I mean, and if we see the tumor reduction in phase 2 trial, then maybe in phase 3 trial, I mean, we can have a different survival, even if we don't have, tremendous amount of tumor shrinkage, because the mechanism is totally different. I mean, this is not cytotoxic therapy. And, okay, an example of an excellent complete remission in a young patient with probably this was unknown, but this was probably a tumor of the appendix with a massive liver metastasis, and we achieved a complete remission after 4 courses of lutetium. Here, I mean, small tumor volume. Actually, the liver was massive, invasive, but all the lesions were quite small, and the receptor density was dramatic. Here, in the first whole body scan of lutetium, you cannot see the kidney and the spleen. And here, in the last treatment cycle, you can see the kidney and the spleen. So all, the tumor was, taking the peptide. And probably, in my opinion, this was the reason why we had such an incredible response. And this is the gallium after 1 year control, confirming that the patient achieved a complete remission. After that, we did the first prospective phase 2 trial in a disease-oriented trial. And this was performed in combination with another cancer institute where I have the privilege to be consultant in Romagna region, in my town. We, according to the data of the phase 1 and phase 2 trial that we did in Milan, we designed the protocol in this way. We stratify patients with risk factor for bone marrow and kidney toxicity and without, first of all. So each group received a cumulative activity ranging from 500 to 750 millicurie. I'm sorry, I'm almost 60 years old, so I still think in millicurie rather than in gigabecquerel. And we divided, instead of 4 cycles, we divided in 5 cycles, because Marta Cremonesi, published an excellent work showing that, dividing the cumulative activity in more cycles, reduce the toxicity. So we are totally in agreement with the Bad Berka approach. And so, in other words, the patient received 100 millicurie 5 times or 150 millicurie 5 times. Very simple. Each cycles 6 to 8 weeks apart to see, to recover eventual, possible toxicity. Activity were administered in patient with toxicity or possible toxicity, mainly hypertension, previous chemotherapy, and previous radiometabolic therapy. So we did not exclude patients that already received yttrium. If they were in progression after yttrium, after a couple of years, we could enroll, but in a reduced amount. So we tried to stabilize what is the minimum effective dose. This is something that the oncologists need to know. We know what is the maximum tolerated, but what is the minimum effective? So this is in my opinion, the most important contribution of the Italian group. So the results are this. We enrolled 70 patients, and we can evaluate 68. I mean, we had 35 patients with risk factor, 43 with pancreatic neuroendocrine tumor, and 25 with the gastroenteral tract. I mean, the majority were G1, G2. We also have few G3, but with a positive octoscan. And, of course, all the patients had a positive and strong octoscan to be enrolled. So, what's the results? Let's divide the pancreatic and the intestine, because the prognosis is different. So this is pathology-oriented, phase 2 prospective trial. This is the first in the world, let me repeat. Well, more or less the figure are the same. 19%, I mean, patient not responding, 23% with complete partial remission and minor response, which is between, I mean, you know, and about 60%. The PFS in this pancreatic in progression was 21 months. If you remember the New England Journal with the everolimus in the similar population, the best was 11 months, and the placebo was 5 months, 6 months. So, of course, now I don't want to see something, well, but you didn't randomize. Forget it. Just compare that. These are very similar population, very similar. And we have 21-month PFS. So encouraging. Then, of course, the next step will be to randomize everolimus versus lutetium. But who's going to pay for that? Gastroentero, I mean, you see here, we have better stabilization. Stabilization, in my opinion, is you know, between 25% and 50% reduction. I'm talking about WHO criteria. But in patient with progression is a disease control. 8% complete remission, and again, more or less 15-20% patient not responding. We have to understand why we have this, because these are all positive to octoscan. And this is the median response, so which is not bad. But the PFS in this population is 30 months. So it compared very well with other study. And this, is an example. At the first cycle, with lutetium we can do, dosimetry and imaging during the therapy, which is very good. And this is the last. Okay? And again, see the difference in kidney uptake at the beginning and the end of the therapy. So maybe we should give more in the beginning and then less in the end. Who knows? Again, we need to, but maybe in the beginning it's better to give 200 millicurie and the last cycle give 100. But this was a prospective phase 2 trial, so I could not change, the rule, so I give 150 for 5 times. But again, if we are talking about tailored therapy, we have to think also to tailor and to modulate the activity injected. Now, and for me this is the most important part of the talk. What is the minimum effective activity? I mean, is there any difference in patient who receive 500 millicurie and patient who receive the 750? This is the response rate, pancreatic and intestine altogether. You see that the 500 millicurie, the 33 patients with risk factor, more or less have, the same figure. And the 750, again, more or less. So there was no statistical significant difference between the two groups. But if we look at the progression-free survival, the higher activity was better than the low activity group. In other words, the patient receiving more than 700 millicurie, had no reached yet the median PFS after 30 months. Whereas here, was about 20 months. And of course, if we put all together, the median PFS between the 500 and 700 is 29 months. So I think these are encouraging results. and tell us that a minimum activity of 500 millicurie is working. Patient who did not reach the activity of 500 millicurie, we have some patients that continue the progression. We did not inject more than 200 and 300. We never see response. So let's say that probably 500 millicurie is the minimum activity we have to inject to see response, and it's very safe. I mean, we had no toxicity. I don't show you the toxicity because we had no toxicity at all in this patient. And now it comes to the FDG, point. Look in this patient. This was not part of the protocol, but 57 of these 68 patients had a PET FDG scan to see the proliferation. This was not thymidine, but so we could not talk about proliferation, but FDG is known to be a prognostic factor. There was an excellent paper by Tina Binderup in Denmark, published in Clinical Cancer Research in February 2010, showing that FDG has a strong prognostic value in neuroendocrine tumor. The paper was in 90 patients treated with chemotherapy, oncological therapy. Few patients were treated with peptide. But so, FDG role in neuroendocrine tumor has been already demonstrated. That's why I ask the majority of patients who have a PET FDG and see the PET negative scan were 24 patients out of 57. And only 2 events in this group of patients. So the PFS, still we don't have the median. The PET positive patient, 28, so, more than 50%, we already have, 13 events and a PFS of 20 months. So there is a significant difference among the group. So we can start to stratify neuroendocrine tumor, G1, G2, but PET positive, PET negative, they have different behavior. And if we look at the literature, this is a important, cornerstone of the neuroendocrine tumor assessment for prognosis. Without PET, we need location of the primary, extent of disease, tumor stage, degree of differentiation, proliferation, grading, age, performance status. But nevertheless, we cannot predict very much to the patient. The response to the therapy in neuroendocrine tumor may vary very much. If we divide it with the Ki67, of course, we have an idea. But again, Ki67 has an intrinsic bias because we have one metastasis, or the primary, we have 1 or 2 slices, and then we only have, the proliferation index, the immunostaining in that slice. But we don't know anything about the other lesion. So it's not comprehensive of the whole body situation of the patient. Nevertheless, according to the grading, we can differentiate it, of course. But with PET, and this is the Tina Binder paper I mentioned, with PET, the survival proportion in PET negative and PET positive, or the PFS in PET negative and in PET positive, just with one single, whole body scan, can be immediately recognized. If you see this gallium, you say, oh my God, we have more tumor than normal liver. But if you see the PET FDG, it's negative. So I can say to this patient, well, probably with peptide receptor radionuclide we can have good results. I'm a bit out of time, I think. I have to finish. And this is another patient with the Ki67 where we have both positive scan, the gallium and the PET. So we investigated the role of PET in peptide radionuclide therapy. And we analyzed 35 patients with the progression treated with lutetium. We assessed the Ki67, etc., etc. These are the patients. We had patients positive to PET even in the G1 group and negative even in the G2 group. the overall response and the PFS, according to the Ki-67, no difference. The overall response and the PFS, according to PET, look, none of the patient in progression after peptide therapy continue the progression. So we have a disease control. We only have 7% with partial remission. These are slow-growing tumors, so we don't have tumor shrinkage, but doesn't mean anything for the prognosis. I mean, I prefer, and if you remember the picture of the lutetium phase 1 trial, where no difference in patient with stable disease and complete or partial remission in terms of survival, I mean, this is an explanation. This is an explanation. And there is a significant difference, I mean, statistically, in this group. Yesterday, I finished to write the discussion of this paper, so I hope to send to some journal soon. And this gives you a better idea of the negative and the positive PET in this series of patients, the difference in terms of PFS. So in conclusion, a higher percentage of G1, G2 neuroendocrine are FDG positive. So I confirm that we have to ask for FDG PET before we start. None of the FDG negative continue the progression. So we can say something encouraging to the patient. You are PET negative. Maybe, I mean, we can control better your disease. And what about the patient with the PET positive? Maybe we can combine the peptide with chemotherapy or with other therapy. I mean, peptide itself is not enough for this patient. So what we need, in my opinion, is controlled phase 2 trial comparing low dose versus high dose. I mean many cycles, few cycles. Hypofractionation, hyperfractionation. Combined therapy with chemotherapy in FDG positive advanced NET. I mean, we cannot give capecitabine or temozolomide to everybody. We have to stratify. And this is a very simple and cheap way, or almost cheap way, to stratify patients. An example of combination of lutetium and capecitabine. This is a protocol that I had approved recently by the Ministry of Health in Italy, because we use a combination of capecitabine and lutetium. And this is my group, and I'd like to thank Lisa Bodei and Marta Cremonesi, that I don't see here in this picture, and Myla Ferrari for the excellent job, and all the group, the chemists, the technicians, and the nurses in my department. Thank you for attention.
Thank you very much. We are running a little late, but one quick question is sorry. The combination of chemo with PRRT. Is it combined? Is it the radiosensitization that you are aiming for, or just a double-pronged therapy?
We decided to give capecitabine in a metronomic way. It means that we don't give more than 2,000 milligrams per day. Actually, we give 1,500, 500, 500, and 500, 3 times a day, continuously. We decided to do this because we had previous experience with capecitabine in neuroendocrine tumor in my institute, showing that this approach that we call metronomic, because it's puff, 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 morning and night, I mean, is effective and reduce the toxicity. In other protocol, they give full doses in terms of capecitabine as a radiosensitizer. We designed the protocol in this way. The patient take capecitabine 3 times a day, 1,500 milligrams, and then receive lutetium 5 times, each 2 months. And at the end, we continue the capecitabine until progression. This is the protocol that will start soon.
Okay, thank you very much. I think we are running out of time.